Now this is one more indication. This is like you have operated, you have achieved a negative margins, but the nodes are positive, or you have some sort of residual disease which is present. Here previously we did not have any option, but nowadays we have this option of giving adjuvant immunotherapy. So what is the data behind giving adjuvant immunotherapy in residual disease post neo-adjuvant chemo-radiation? This is a CheckMate 577 trial where they have taken stage 2 or 3 esophageal cancers or gastroesophageal junctional cancers. Both the histologists were included, and initially they gave them neo-adjuvant chemo-radiation. They gave them a cross kind of approach, following which the important inclusion features were that it should be an R0 resection. Positive margins, you do not take those patients. They should have some residual disease. That means that neo-adjuvant chemotherapy has worked, but it has not completely decreased the disease. Now, they were randomized between nivolumab for 1 year versus placebo. The primary endpoint here was disease-free survival. Let us see what happened. So, there was almost a doubling of disease-free survival. So, previously all these patients, around 70% of them had relapsed, but after adding nivolumab in such patients, there was the disease-free survival median was 22 versus 11 months. The p-value was significant. The updated 5 years was, yes, you can see that the median overall survival was improved to the tune of almost 15 months. So there was a 15-month difference between the median overall survival, but unfortunately the hazards were not significant and the p-value was not significant. This was the author's conclusion. What, at least in this particular subset, where you have completely resected, margins are negative, but you have some sort of residual disease following neo-adjuvant chemotherapy, you can consider this option in affordable patients, because it definitely improves the survival. So we'll just skip this slide. So this is just a slide that some surgeons, what happens is the patients actually undergo neo-adjuvant chemotherapy, the surgery has been complete, but some senior surgeons want some sort of adjuvant chemotherapy to be given after the surgery. Is it really helpful for the patient? No, it's not going to add any benefit, because you're going to actually add the same chemotherapy and it's going to be more toxic for the patient. Adenocarcinoma management is actually quite very easy. So now we go for a perioperative kind of approach, but in case if the patient have undergone a direct surgery, the surgeon has been excellent and R0 resection has been achieved, node negative till T2 you don't need to do anything. But for a T3, T4 or node positive disease, you generally give some adjuvant chemotherapy or chemo-radiation depending on the radiation oncologist's preference. But for R1 and R2, generally we go for adjuvant chemo-radiation. So if the margins are positive, this is an indication to go for radiation. But if it's only a T3, T4 or node positive disease, chemotherapy alone is enough. After prior NACT, suppose they've gone for a good approach and perioperative chemotherapy has been given. Again, in this particular scenario, if you have given a chemotherapy prior surgery, go for the same chemotherapy. But if you have not, if the margins are positive or something, along with chemotherapy, you may add radiation after chemotherapy. So regarding the chemo preferences in squamous cell cancer, generally we go for a combination of paclitaxel and carboplatin, whereas in adenocarcinoma, it's generally a combination of either CAPEOX or FLOT-based therapy, but FLOT post-surgery is very difficult to tolerate, but in a very good patient with a good PS and if the fitness status is good enough, you can, yes, go for it. So the final summary is that it's a complex disease requiring multimodal management. Surgeon alone or radiation oncologist or medical oncologist alone cannot do anything. It's a team-based approach. Neo-adjuvant is generally followed, but if you want adjuvant treatment, there are only limited scenarios where we utilize it. But definitely adjuvant nivolumab is one thing which can be offered in patients who have received neo-adjuvant chemoradiation but with a residual disease. Thank you. Thank you so much.